Medurstand-Understanding Medicine.
I am Professor Azizur Rahman, and today we're going to talk about this condition called prediabetes. The name is self-explanatory. It is actually a condition just before diabetes. Now, the title also includes do something. Why that? Because prediabetes is not a benign condition in its own right, but more importantly, it can progress to full-fledged diabetes. And you all know how bad this diabetes is. So I think this prediabetes provides us an opportunity to intervene and prevent diabetes. So that opportunity should be translated into doing something. So first of all, very briefly, prevalence of prediabetes and diabetes. This is the global facts and figures by International Diabetes Federation, the latest figure 2021. 1 in 10 adults ranging from 20 to 79 in the world has diabetes. That is 10% of the adult population. That makes it 537 million people. And adults in the same age group, 1 in 18 have impaired fasting glucose. Impaired fasting glucose is a condition where your fasting is high, but the rest of the day readings are okay. 319 million people. Then 1 in 9 have impaired glucose tolerance. That means their postprandial sugar is above normal, their fasting may be normal. So these people, the one with impaired fasting glucose and impaired glucose tolerance, collectively called prediabetes, they actually constitute more than diabetic patients. So these are patient diabetes in the making. So I think this is where we can do something to prevent the development of diabetes. Figures in Pakistan, it is 1 in 4. That means very, very alarming. 1 in 4 means about 26% people in adult range are diabetic patients. Although many of them, they are not known cases. When we do survey, we find out they're diabetic. Many of them are not known, but if you go to the population, you'll find out that 25%, 26% of our population are diabetic. And 1 in 10 have this prediabetes. So this condition, prediabetes, is very, very common. This is the National Diabetes Survey of Pakistan 2016 and 17. Again, the same figure, 1 in 4% had diabetes, 26%. And many of them, they have additional comorbidities. What is the importance of comorbidities? Because these conditions, they increase diabetes related morbidity and mortality, especially cardiovascular. So I think these figures are very alarming, and this figure is also alarming. Now let's talk about the definition of prediabetes. There are two definitions. One is impaired fasting glucose, the other one is impaired glucose tolerance. Impaired fasting glucose means the fasting sugar is above the normal level. If your fasting sugar means 8 hours overnight fasting, 8 to 12 hours actually. 8 to 12 hours overnight fasting sugar should be less than 100. Even 100 is considered to be in this range. And if it is between 100 and less than 126, it would be prediabetes or impaired fasting glucose. Okay, and if it is above 126, it is diabetes. Normally we like to do more than one readings unless the reading is clearly abnormal. Somebody's sugar is 300, then of course you don't need to repeat, and somebody's sugar is 60, 70, 80, 90, that means clearly normal. But borderline readings especially should always be repeated before you make a label. If you go by 2-hour plasma glucose on OGTT, and this test is not done very often these days, I think 2 hours post meal, and the time starts when you start your meal. From that onward, 2 hours after that, if your sugar is less than 140, you're normal. This would actually depend on the meal size and meal composition. It is possible that you have impaired postprandial glucose, but still it is normal because your food didn't have any carbohydrates. But after glucose tolerance test, if your 2 hours readings is more than 140 but less than 200, this is pre-diabetes, and more than 200 is diabetes. HbA1c was not actually the diagnostic criteria till I think 2010. Before that, we used to define pre-diabetes on the basis of fasting sugar and 2 hours postprandial, post-glucose load. But nowadays, we rely more and more on A1C because this is much easier test and very, very reliable. If someone's HbA1c is 5.7% or less than 5.7% actually, any time of the day, that is normal. From 5.7 to 6.5 is pre-diabetes, and 6.5 and above is diabetes. Okay. Now please note down, some authorities use fasting plasma glucose as 110 mg per deciliter and HbA1c of 6% as cut point for pre-diabetes. In my presentation, I would use this cut point of 100 and 5.7 because that is the cut point given by ADA, and that is what is widely accepted. But some authorities like WHO says 6% A1C and 110 blood sugar fasting, that is where pre-diabetes starts. So either of the two or both of the two would constitute pre-diabetes. What is the pathophysiology? It is the same as that of type 2 diabetes. Now, basically, in earlier part of type 2 diabetes, and even before type 2 diabetes, the pre-diabetes, the main player is insulin resistance. This insulin resistance is because of sedentary lifestyle, because of weight gain, and because of some bad genes. So one has insulin resistance, and that is associated with type 2 diabetes, hypertension or prehypertension, impaired glucose tolerance, obesity, especially central obesity, polycystic ovarian syndrome, low-grade inflammation, and inflammation can also cause many problems. Acanthosis nigricans, decreased fibrinolytic activity, and dyslipidemia. In dyslipidemia, HDL is likely to be low, LDL is likely to be high, and LDL is also likely to be qualitatively abnormal. Patient with insulin resistance, they are likely to have small dense particles which are very atherogenic, and triglycerides are also likely to be high, and if triglycerides are high, then VLDL will also be high. Now all these factors would actually lead to atherosclerosis and endothelial dysfunction, and this is what is actually responsible for increased macrovascular complication in diabetes and in also pre-diabetes. This is how the disease process develops. Now, this is insulin resistance. Now, please note down that if your diagnosis is made here at this level, actual diabetes develops much before that. On the average, 5 years are wasted before the diagnosis is made. So, patient is actually diabetic for maybe 5 years before a formal diagnosis is made, because diabetes is mostly asymptomatic disease, and pre-diabetes develops even before that. So it is somewhere here, maybe 10 years before the diagnosis, the actual disease process starts. Now this is where insulin resistance starts rising, and then later on it becomes static. Because of insulin resistance, there is hypersecretion of insulin as an attempt to compensate for resistance, and there is hyperinsulinemia, and this compensatory hyperinsulinemia keeps glucose normal in this range till the end of this phase. Blood sugar fasting and postprandial is kept within the normal range because of hyperinsulinemia is compensating for insulin resistance. But as beta cell loss is progressive, then there is no further compensation and insulin starts decreasing, and then full-fledged diabetes characterized by fasting as well as postprandial hyperglycemia that develops. Yet this is pre-diabetes phase, and this is where some metabolic derangements are already occurring. And note down this macrovascular complication, they also start developing before the diagnosis of diabetes and before the onset of diabetes and in the pre-diabetes stage also. So that makes pre-diabetes an important condition. So basically it's a continuum, it's a whole spectrum starting from predisposing factors. I will talk about some of the factors which can predispose to pre-diabetes and then diabetes, and later on it could lead to diabetes associated complication. So this is the whole spectrum, and the lucky one would have an early diagnosis, and some people are very unlucky, their diabetes is diagnosed only when complications have already developed. Our aim should be to make the diagnosis as early as possible. I think ideally at this level, predisposing factor, we should start intervening maybe with lifestyle changes at this stage. Why is it important? Pre-diabetes, why is it important? We have already, I think, talked about it briefly, but let me say it again. There are 3 reasons why I say pre-diabetes is important. One, it poses an increased risk of CVD. I just showed you a slide where macrovascular complications start developing before the diagnosis of diabetes is made in the pre-diabetes stage. So in itself, it is like a milder form of diabetes. It will progress to diabetes. I think 80 to 90% will progress to diabetes if no intervention is done. I'll actually show you the figures, how many patients they develop diabetes. So pre-diabetes should be considered as something which is progressive, not transform into diabetes, but it would progress to diabetes. And it's important because it provides an opportunity to prevent diabetes and diabetes associated cardiovascular disease. So that is actually a great opportunity, because these complications can be prevented or delayed. Once these complications develop, then our treatment options are limited grossly. So pre-diabetes can increase the risk of CVD. In addition to the risk of progression to type 2 diabetes, the pre-diabetes state itself is a toxic state associated with the spectrum of microvascular and macrovascular complications. Mostly macro, but some microvascular complications are also seen. So you can see it, cardiovascular disease, this is cardiovascular, this is cerebral vascular disease, retinopathy, neuropathy, microalbuminuria, nephropathy, peripheral vascular disease, type 2 diabetes. So all are associated with this condition. This is a very interesting slide, and this is where typically we make a diagnosis. The current point, the point where we make a formal diagnosis of diabetes is A1C of 6.5%. So this is where diagnosis is made. And microvascular complication, they start developing after A1C of 6.5 is achieved. Why so actually? And do you have any idea where this figure of 6.5% come? Actually, the studies have shown that these characteristic diabetic microvascular complication, they suddenly start rising. The prevalence suddenly start rising once A1C reaches 6.5 threshold. So that is why the diagnosis of diabetes is made at 6.5. So microvascular complication typically start developing after the diagnosis, although some patients, as I will show you the data, would have some microvascular complication in this phase also, in the later part of pre-diabetes. But macrovascular complication, they start developing much before the diagnosis of diabetes is made, maybe as early as 10 years ago. In the pre-diabetes stage, and maybe before pre-diabetes stage in predisposing factors. And then in that range, it would be progressive from predisposing factor to the threshold where diabetes is made. In this pre-diabetes phase, it would be the incidence of these complications would be proportional to the level of A1C. And beyond that also, so as your A1C rises, the chances of macrovascular complication and microvascular complication increase. Now, in pre-diabetes, individuals with pre-diabetes are at significant risk of diabetic vascular complication. CVD risk is increased by 10 to 40%. Stroke risk is increased by 32 to 34%. Heart failure risk is also increased. Coronary artery disease risk is also increased by 10 to 28%. Peripheral arterial disease is also increased by 26 to 28%. So pre-diabetes detection gives us an opportunity to prevent these microvascular and macrovascular complications. This is the meta-analysis of 18 clinical trials evaluating the risk of CV disease among patients with impaired glucose fasting or impaired glucose tolerance. So all these studies, they show that these dots, they fall on the right side of this line. This means both in impaired fasting glucose and impaired glucose tolerance, in both types of prediabetes, the incidence of CV disease is more as compared to those who do not have these conditions. Now, when it comes to microvascular complication, the incidence of microvascular complication is approximately 23% in prediabetes. Although patient may not be symptomatic, but when you do detailed screening, you do a dilated fundus examination, you do nerve conduction study, and then you might find that 8% have diabetic eye disease, 11% have peripheral neuropathy, and 9 to 30% may have CKD. CKD may be just albuminuria or increased albumin creatinine ratio, but there may be some level of CKD in pre-diabetes stage also. Now, pre-diabetes can progress to diabetes, but I would say pre-diabetes will progress to diabetes unless something is done, because I consider it as diabetes in the making. Whatever factors predispose to pre-diabetes, if not controlled, they will go on and patient will develop diabetes. Now, this is what has been shown by the trials also. According to American Diabetes Association, 70% will progress to diabetes mellitus. And according to Chinese diabetes prevention trial, extended over 20 years, 93% will progress to develop diabetes. That means practically everyone. And risk of conversion to diabetes mellitus is proportional to the existing A1C. Now you can see here, if you have A1C of 5 to 5.5, which is normal, upper normal, there will be 2-time risk. And as your A1C rises, your risk of diabetes, developing diabetes, increases to 5-fold and then 20-fold. So I think that confirms the statement that pre-diabetes is actually diabetes in the making, a progressive disease. Risk factors and assessment. There are some risk factors and some criteria have been laid down by ADA for the screening and for testing asymptomatic individuals. In adults, if your BMI is more than 25, and this is the global figure, but we all know that in Asia, we have obesity, visceral obesity at a lower level of BMI also. So for our population, for Pakistani people, if your A1C is 23 or more, or you have any of these things, family history of diabetes mellitus, ethnicity, hypertension, CVD, HDL of less than 35, or TG of more than 250, or if you have polycystic ovarian syndrome, or if you have history of GDM, that is gestational diabetes mellitus, or you have NAFLD, you have fatty liver, or if you have acanthosis nigricans. So if your BMI is more than 23 and you have any of these, whatever your age, maybe you are as young as 20 years, you need to be screened for pre-diabetes. And everyone should also be screened at the age of 45. You may not have any of this, but I think it is recommended by ADA that everyone should have some screening test at the age of 45. And that could be A1C, that could be fasting sugar, or that could be 2 hours postprandial. But I think A1C would be perhaps the best. Now in children, the criteria are different. At puberty or at the age of 10, as young as that, if someone has obesity and if there is family history of diabetes. Okay, so if you have a family history of diabetes and you are 10 years, or if you have you achieve puberty, I think screening should be done. And if the values are borderline, then they should be repeated maybe annually. So all these patients should have screening. Screening provides an opportunity of early diagnosis and intervention with the lifestyle changes and medication if needed. Now, scoring system for pre-diabetes, again given by ADA, American Diabetes Association, and you can read through it. I think I will just let you read. I'm not going to read through it, but there are various criteria according to age, the gender, and ethnicity, and other criteria. And if you sum up your score, and then if your score is 5 or more, that means you are at risk of developing pre-diabetes. Then whatever your age, I think you need to have the screening test. Now let's talk about the management. Since we have already acknowledged that this is a pathological state, now we had to do some management. What are the treatment options? One is intensive lifestyle intervention. That obviously refers to weight reduction, regular exercise, healthy eating. Particularly, all should translate into weight reduction. And then use of medication. There are various trials and they have shown benefits with metformin, and metformin is safe, effective, economical, and most studied. But we have studies with acarbose, but acarbose is notorious to cause gas in the abdomen, and pioglitazone is also effective, maybe more effective than metformin, but pioglitazone causes weight gain and also may precipitate heart failure. So you have to weigh the risk of weight gain and heart failure against prevention of diabetes. And GLP-1 receptor agonists, and this is again very effective to prevent development of diabetes from pre-diabetes, but they are generally very expensive, and this comes in the form of injection. Though there is one oral tablets also, but these are all expensive medicine. I think out of all these medication, metformin is the one which gives us the best hope because it is very cheap and very, very widely available and effective and safe. Now, these are various studies, and this is just a summary overview of trials in pre-diabetes. You can see these are the names of the trials: Diabetes Prevention Program, very famous study, DREAM, STOP NIDM, and this was about acarbose, and ACT now, this is about pioglitazone. And they all included patients with impaired fasting glucose, those individuals whose fasting sugar was between 100 and 125. So they were included, and this is a number. In this study, metformin, in this DREAM, rosiglitazone, stop NIDM, this acarbose, and in ACT now in pioglitazone was used. This is the duration, and all of them showed significant reduction in conversion rate. Conversion rate means pre-diabetes going into diabetes. So all of them, they are effective. This is the guideline given by American College of Clinical Endocrinologists. Quite busy slide, but I'll just go through this part. If somebody has developed hyperglycemia, maybe below the level of diabetes, fasting glucose more than 100 but less than 126, and 2 hours fasting glucose, 2 hours postprandial glucose more than 140 but less than 200. These patients, if they are low risk, they may be treated with metformin and acarbose, and you can consider TZD and GLP-1 receptor agonists in some cases. Of course, you have to justify this additional cost and increase risk of the medication against the gain. I would believe that mostly, I think should of course intensify weight loss therapies, but metformin should be the treatment of choice. This is the management strategy in pre-diabetes depending upon one's A1C. All these A1Cs are in the range of pre-diabetes, but they have divided that into three further categories. Hemoglobin A1C, risk of stratification, all should be stratified, and A1C target should be less than 5.7% in all the categories, and lifestyle modification, at least 16-week course should be offered to all of them, and the aim should be to reduce weight by minimum 7%, and in those who have BMI of 25, in Pakistan I said 23, all three should be in all three categories. Even if your A1C is just 5.7, just entering pre-diabetes stage, I think you should aim to lose weight 7%. Then physical activity of 150 per minute per week should be done in all categories. But when it comes to pharmacological therapy, I think in those patients who have A1C of 6.1 or less, they may not be offered metformin unless they have additional risk factor for diabetes or CVD. In that case, of course, metformin can be given. But otherwise, metformin should be offered to those individuals who have A1C of 6.2 to less than 6.5. Metformin along with lifestyle intervention can be given. Now, those patients where lifestyle changes have failed, in these two categories, metformin can also be given. Bariatric surgery is also justified. We know this is an expensive surgery and not without risk because it's a major surgery, but this is justified in patients who have this A1C very close to diabetes, but they have comorbidities also, or those who have failed on intensive lifestyle intervention and also metformin. One can consider bariatric surgery if their BMI is more than 40, or if they have BMI of 35 or more plus one or two additional risk factors. So this would be very subjective and it would depend on patient's motivation, but weight lowering therapy should always be considered in patients with diabetes or pre-diabetes. Lifestyle intervention, we know these are various studies. Meta-analysis showed 29% reduction. Finnish diabetes prevention study showed 58% reduction. And this is on lifestyle intervention. This is the best study we know, lifestyle intervention, the 58%. And this is Chinese prevention study, 45% reduction. And again, Chinese study, 39% reduction. And this is DPPOS. This is diabetes prevention program, but the follow-up study and ongoing study. I think this was then the same patient study for next 20 years, and again 27% reduction. Initially there is more reduction, but later on there is in many people they develop diabetes, because problem with lifestyle changes are that they are difficult to sustain. So that is why sometimes we have to use metformin. The effect of metformin is much more durable. So American and European guidelines advocate lifestyle changes as a first measure for the prevention and management of diabetes mellitus. Even modest weight loss delays progression from pre-diabetes to type 2 diabetes. After losing 7%, you may still be overweight, but your chances of going into diabetes will be significantly reduced. This is diabetes prevention program outcome study, 22 years. I will not go into the details, but this is intensive lifestyle. Weight loss target was of 7% and 5% actually achieved this weight loss target in 3 years. A restricted low fat diet and 150-minute exercise per week. Now please note down, they had restricted fat. Carbohydrate was allowed in the normal quantity. Personal trainer and individual lifestyle program, behavioral modification scale. So this was very specialized care provided to these people. It is possible that in real life, because all these would not be possible for everyone, so the effects may be less impressive as was shown in DPP study. And in some patients, in one arm they used glucophage, which is metformin. At that time, 850 milligram immediate release tablet twice a day was given. And later on in onward study, they use glucophage XR 750 tablet twice a day. Now, then this study was also, I think, included into three phases, phase 1, 2, and 3, and you can see that metformin was effective in reducing the conversion of pre-diabetes into diabetes in all stages. Initially, the difference between lifestyle changes and metformin was more in favor of intensive lifestyle changes, but as time passes, the difference became less because lifestyle changes are difficult to sustain, whereas metformin, effect of metformin is more durable. So both, I think at a certain point, both become more or less equivalent. Benefits of intervention, this is based on 2 hours postprandial glucose. Now I would like to make this point. When this DPP study was done, at that time HbA1c was not considered to be a diagnostic criteria for diabetes or pre-diabetes. So this study was done based on 2 hours postprandial glucose. These patients, they were first classified as cases of pre-diabetes based on this value, and then they were classified as diabetic based on again this value, postprandial value. Now in intensive lifestyle intervention, 58% prevention, whereas in metformin 31% prevention. But there is a catch here. Somebody did a very intelligent analysis. This was based on 2 hours postprandial glucose. Now you all know that metformin primarily prevents hepatic glucose production and it primarily controls fasting sugar. So if the criteria is fasting sugar or A1C, then probably the result would be different. And this one again, lifestyle changes would probably meal size portion, if the meal portion is reduced, it would probably have more effect on the 2 hours postprandial. So maybe this is overrepresented. So then somebody made the analysis again based on HbA1c. Now interestingly, now you see that when it comes to HbA1c, the prevention is more or less equivalent. So whether you use lifestyle intervention or you use metformin, in almost the same percentage of the patient, which is slightly less than 50%, you are able to prevent diabetes. So based on A1C, metformin is as effective as intensive lifestyle changes. So this is very interesting observation. DPP and DPPOS 22 years outcome metformin benefits. You can see in all graphs, this gray one is intensive lifestyle changes and this red one is metformin. In all of them, there was significant reduction and at all levels, this lifestyle intervention was slightly more effective than metformin alone. So this is like metformin benefits in a 10-year follow-up study since DPP. The lifestyle intervention initially lost, then partially regained weight, whereas weight loss in the metformin group was maintained. CVD risk factors, favorable effect on lipoprotein subfractions, C-reactive protein and tissue plasminogen activator in DPP study. Reduced incidence of the metabolic syndrome by 17% versus placebo. 14 years after randomization, significantly lower presence of severity of coronary artery calcium score in men versus placebo. There were favorable trends with metformin in stroke reduction and for cardiovascular events in the subgroup of people who started the study before the age of 45. Metformin was associated with non-significant but 12% low risk of cancer compared with placebo group. This is additional benefit. So participants who did not develop diabetes had significantly lower state of the eye and kidney disease. Cardiovascular disease at 57%, 37%, and 39% respectively. Efficacy of metformin in pre-diabetes in other studies. The slide I showed you was about DPP, Finland study, but various studies, similar studies have been done in Pakistan. This is Iqbal Haidari. This is Indian study. This is a Canadian study, a Chinese study, another European study, I think. And all these, they have shown significant reduction. So it actually reinforces the concept that pre-diabetes is a progressive disease, and if you intervene with the lifestyle intervention or with metformin, you can actually stop further progression and you can prevent associated CVD disease. Meta-analysis metformin treatment in persons at risk for diabetes development pooled result of 31 trials. Metformin reduced BMI by this percent, fasting glucose by 4.5%, fasting insulin is also reduced. A reduced fasting insulin means improvement in insulin sensitivity. Insulin resistance reduced, and triglyceride reduced, LDL reduced, and HDL increased. We know HDL is a friendly lipoprotein that is increased and reduced the incidence of new onset diabetes by 40%. Meta-analysis of different metformin studies. There are some benefits. I will not go into detail because that will take us beyond the scope of internal medicine, and I think I will also have to restrict to a maximum time of 45 minutes for this lecture. Metformin benefits beyond glycemic control. Beyond glycemic control, it works in reducing weight. If you are motivated, it can help you to reduce some weight, and in some patients, especially hypertensive patient, additional use of metformin, even if you're not diabetic, the chances of developing left ventricular hypertrophy is reduced. And we know left ventricular hypertrophy in its own right has got certain morbidity. STEMI, patient who develop myocardial infarction, again non-diabetic, if they are given metformin, their chances of developing complication and infarct size progression is reduced if you use metformin in that phase. Small vessel angina, sometimes patient may have angina but coronary angiography may not show any abnormality. That is small vessel angina. The incidence of small vessel angina is also reduced by metformin. These may constitute future indication of metformin, but even now when we prescribe metformin, we also hope that patient will get benefits here. Now, based on this data, International Diabetes Federation, American Diabetes Association, European Association for Study of Diabetes, European Society of Cardiology, and Australian Diabetes Group, and Australian Diabetes Group for Education, and Canadian Diabetes Association. All of them, they have recommended lifestyle intervention along with metformin as first-line therapy in pre-diabetes. We have seen the benefits of intensive lifestyle changes, and we have also seen the benefits of metformin. I think best approach would be to give maximum benefit to the patient by prescribing both intensive lifestyle changes and metformin, both simultaneously. What is the necessity of intervention? We have already discussed it. Pre-diabetes itself is associated with significant morbidity and mortality, and it can progress to frank diabetes in 70 to 90% of the cases. And we have seen from the evidence that intervention can prevent both of these. Progression to diabetes and associated cardiovascular complication can be prevented by intervention. So that is the need for intervention. Choosing between intensive lifestyle intervention and metformin. Intensive lifestyle intervention really works when you can do and sustain. They are difficult to do and they are more difficult to sustain. But if somebody can do and somebody can sustain, he can really benefit. And exercise is not an option for someone, maybe particularly people who have disability, elderly patient, some cultural difficulties in some ethnic groups, and also diet is also not an option for some cases like economic reasons and availability of specific diets. So I think intensive lifestyle changes definitely has a lot of value, but there are some difficulties also. Whereas in metformin, it is, in my opinion, much more doable and sustainable. Now, patients' perception may be different. Patients always hate taking meds. I think if properly counseled, many would accept metformin at the level of pre-diabetes also. So I think, and once somebody accepts this medication, it is much more easy to continue taking metformin as compared to continuing lifestyle intervention. This is not to say, not to discourage lifestyle intervention, but that is the actual real life difficulty. So I think metformin has the advantage. Although metformin, some people like 5 to 10% people may not tolerate, but if properly counseled, started with the low dose or maybe with slow release formulation, many would tolerate when they understand the benefit. So I think both work, and if both work, I think why not both? That makes very, very good sense. All patients with pre-diabetes should be offered both. So this is metformin. I consider a magic pill. Why do I say so? It is incredibly effective, one of the most effective medicines, minus insulin and GLP-1 receptor agonists. It is very, very effective, the most effective drugs. Incredibly safe, minus 5% people who develop GI upset. Others, it's very, very safe. Initially reported lactic acidosis. I think that is also in the latest studies shown that the actual incidence of lactic acidosis is much less than previously reported, and it is incredibly cheap. I think you cannot win on this point. Very, very cheap drug. So based on this, I think we can use this drug. When it comes to other drugs, we start oral anti-diabetic, we make combination, we increase dosage, and then we consider other injectables, maybe GLP-1 receptor agonists or basal insulin. Then patient has to go on to full-fledged insulins. Whereas metformin, it is started at the pre-diabetes stage, right? Even before diabetes, metformin can be started at pre-diabetes stage, and it works at all stages of diabetes, even when somebody has developed complication. It is recommended that if somebody develops diabetic nephropathy of grade 3, GFR comes below 30, then it is recommended to discontinue metformin. Not because metformin is causing nephropathy, but because metformin is excreted through kidneys, and if there is marked reduction in GFR, there is a risk of accumulation. So that is why generally it is recommended that metformin should be reduced. But I personally think that metformin may still be continued in a smaller dose, much smaller dose, maybe just 500 milligram. But this is my personal view. Recommendations are, if someone's GFR is less than 30%, metformin should be discontinued. And once GFR is between 45 and 30, metformin dosage should be restricted to 1 gram. So now I'm going to present the summary in the form of a quiz. I would like your interaction. Which of the following is not the option? We are talking about pre-diabetes. In this context, which one is not the option? Screen high-risk individuals. I think we should screen all high-risk patients. Screen everybody at the age of 45. You may not have any risk factor, still A1C or fasting sugar should be done at the age of 45 in all men and women. Reduce at least 7% of existing weight if your BMI is more than 23%. I think even if you have not yet developed prediabetes, 7% weight reduction should be aimed. Then do minimum 150 minutes exercise, physical activity per week, which could be walking, cycling, swimming, gymming, low level of exercise, aerobic exercise. Again, I think everybody should agree on this. that those with pre-diabetes and those who are predisposed to develop pre-diabetes should do this. I think everyone, but these patients particularly. Do high intensity exercise twice a week. This is also recommended by ADA that 2 sessions per week of high intensity exercise like weightlifting or sit-ups like this, that should also be included in exercise plan. That also improves insulin resistance, and that also leads to better muscle mass and give somebody a better body shape. Reduce caloric intake from 500 to 1000 calories per day. This is also recommended. Depending upon your existing weight, you should go on 1000 calorie less or 500 calories less diet. So I think these are all valid options. Consider metformin as a preventive therapy if your A1C is 6.2% and if intensive lifestyle intervention has been tried but has failed, or if your A1C is 5.7 to 6.2 in the pre-diabetes but you have increased cardiovascular risk because of additional pathologies like dyslipidemia, like hypertension. Those conditions should be treated also, but they would also add the risk here. So I think these patients should be treated with metformin. So this is not the option. Do nothing is not the option. Okay, all these should be done in pre-diabetes, but if I have to attempt this questionnaire, do nothing is not the option. With that note, I will end my presentation. Pre-diabetes, do nothing is not the option. You remember my opening slide was pre-diabetes, do something, and my ending slide is pre-diabetes, do nothing is not the option. You have to do something. You have to adopt a healthier lifestyle changes, and if needed, you have to use metformin to prevent development of diabetes. Thank you very much. This is Professor Azizur Rahman from Medurstand, and I hope to see you in my next video also. Thank you very much for joining.